Gaurang sir, good evening.
Good evening. Good evening. Good evening. So actually, what has happened?
Sir.
We have got uh, this thing, a good case, but all the we have got X-rays, uh, but the sonography probably I think films are not there. Otherwise, everything is there.
Doesn't matter. Sir, it doesn't matter.
Because mainly I think it is in that you must be having lots of collection, correct?
Sir, fuel का मिल जाता है. The cases are not too many, but still I have many.
So I think at the end you can also, like in a short cases or as a quiz, you can just show them and ask them.
Sir, they are all at the hospital. I have hardly anything at home now.
Okay, no problem. If you have got
Mm.
something in your desktop or something, you can just show them. We'll just wait for Dr. Gite and them to join and
Yes, sir.
we'll start. महेश्वरी को भी एक मैसेज कर देता हूँ.
Sir, he is in Seoul.
अच्छा, सियोल में क्या है? बहुत सारे लोग गए.
World Congress and Urology.
Okay, it is there only. World Congress.
Manoj.
But they will come tonight, na? Many of them.
Sir, no idea.
ఇంకా వేరే రెండు క్వశ్చన్స్ ఏమన్నా అపిట ఆ రెండు కలిసి జరుగుతాయి.
Rafai, can you just make yourself mute? Mr. Rafai.
ತಿಂದರ್ ಜಾತಿಯಿಂದ 3 ಬಾಳೆಹಣ್ಣು
ಮೂರ್ ಬಾಳೆಹಣ್ಣು
ಚೋಟ ಬಾಳೆಹಣ್ಣು ನಂಗೆ ಇಷ್ಟ ಅಲ್ಲ ಬಾಳೆ
ನೋಡಮ್ಮ ಇಲ್ಲಿ ಕೊಟ್ಟಿನ
Harish, can you mute yourself?
ಕುಡಿ ನೀರಾಯ್ತಾ
Who is answering today?
Good evening, sir. Myself, Dr. Giriraj, sir, from Puttapatti.
Yeah, Giriraj. And who else?
Good evening, sir. Swapnil.
Swapni. Good.
Yes, sir.
Okay. I think we should start then because Dr. Gite will join soon. And Hiren is there and mainly Dr. G.R. Sharma is there. So,
ಗುಡ್ ಈವ್ನಿಂಗ್
Sharma ji, can we start now?
Sir, just 1 minute.
Huh?
Let the recording start. The host is still joining because
Okay.
otherwise we'll miss the recording.
Okay.
Amit
Good evening,
Mishra,
sir.
host, has joined. He has started the recording. Mr. Amit Kumar Mishra, can you also make Dr. Gaurang Shah and all the students co-host?
I'll make Gaurang Shah host. Who else you want me to make co-host?
Dr. G.R. Sharma sir, Dr. Hiren Sodha sir, Dr. Giriraj and Dr. Swapnil. And if I missed out anybody, then okay. Sir, recording has started. Now you can start the meeting. Gaurang sir, you can start the meeting.
Yeah. Brijesh?
Yes, good evening, sir. So, mother of a 1-year-old male child presented with the complaint of child crying on and off while passing urine since 2 months and increased frequency since 1 month.
Yes. Giriraj?
Yes.
Now this
yes.
is the history now. Just tell us how you are going to proceed.
Child when presented a child line associated. is there a child any associated with fever or not? Is there a child? Sir, I like to ask any other associated history of fever or not, and how's the I will like to ask some previously how the at what month child born, like it is a term born or preterm born child, and whether is there any antenatal scan was done which shows any hydronephrosis in the kidney or not, and whether is I think I saw this. Antenatal history, birth history.
See, here the history is totally different because a patient is not giving history, correct?
Yes, sir. Yes, mother.
So now this history I will just like to add.
Yes, sir.
Actually, the history is that the child had undergone circumcision.
Okay.
Okay.
Okay,
And
sir.
after that, mother has noticed all this. So
Oh,
now
okay.
you tell us.
Sir, after circumcision, if these symptoms started, my first thing I will think about like meatal stenosis, which is more common post circumcision in children's, that meatal got stenosed. So that my first impression in my mind will come the meatal stenosis, and then I will think about the other possible diagnosis which could be leads to these symptoms, like which is most common, like PUV, and the other diagnosis like anterurethral wall, or maybe it could be neurogenic bladder also. So that's why while passing urine, child having crying, and as well as increased frequency of passing urine because it's not able to empty the bladder properly.
Only one thing
Yeah.
I would like to add, ki PUV is not the commonest. When somebody presents with increased frequency following circumcision, you are very right in saying
Yes.
that it could be meatal stenosis and subsequent problems. But
Yes.
at the same time, infection
Okay.
is the most common thing.
Ji, sir.
Then you can add even vesical calculus is known to occur
Ji, sir.
at this age, and then I would say PU wall, because PU walls is something which is there prenatally. So somebody presenting at the age of 1 year can happen, but it won't be the first diagnosis.
Ji, sir. Okay.
Dr. Sharma,
Ji,
can
Yes,
you
sir.
just tell them what are the important things they must ask mother about this?
See, if they say ki the history, what he has been mentioned is very significant. He was asymptomatic 2 months back, and then he started crying while passing urine, and then has increased frequency. So simple. What you are going to look, what happens is ki once you know the case, you are sorry. You start thinking in terms of and start answering PU walls.
Yes, sir.
Think this way. Circumcision, subsequently, your first thought process was very right. And I would restrict myself to this much. History of fever, history of loose motion, history of constitutional symptoms, and pulling at the penis. These are the common things.
Okay, sir.
And only one thing is that many a time, even the small, trivial, any trauma or anything may, precipitate the feeling that thing has started a symptom, and it may be actually existing earlier, but people are, anticipate that it is only because of after that trivial injury or some complaint, all these things have started.
Yes.
In my practice, the commonest way in which I have seen these patients present is when they have got a vesical calculus, the patient presents with increased frequency, some difficulty in voiding, On examination, there is phimosis. They ask if there is ballooning of prepuce, and he undergoes circumcision. And after 50, for the first 2 to 3 weeks, the parents are under the impression that this is a side effect of surgery which will subside over a period of time. That doesn't happen, and then after a month or two, they end up coming to some other doctor saying that the symptoms are persisting. And the next thing that happens is an evaluation by sonography which detects a bladder stone. Yeah. So what next now?
So next I will as any further history. As I already mentioned that any associated with fever, vomiting, uh, uh, any antenatal previous history which suggest any antenatal hydronephrosis there or not, and whether it's a preterm or a term baby, that we antenatal history we have to be asked. And history, I would like to examine the kid, whether is a kid is active or not, whether is sick or how's the general condition. When is after general examination, then I would like to proceed how's the abdomen, whether bladder is palpable or not. Then I will then any tenderness in the abdomen. Then I would like to
You
do
come
the.
to that. See, no, go slow.
Okay, sir.
You have asked the history.
Yes, sir.
All things come negative. Then you come to the examination.
Yes,
You
sir.
start with the standard format, TPR,
Okay, sir.
weight of the baby.
Okay, sir.
Weight is something very important in children.
Oh, okay.
All your medications and subsequents will be based on the weight only.
Yes, yes, sir.
Many times in these children, now when you are examining them,
Yes, sir.
it won't be a bad idea to see them pass urine, you know.
Okay, sir.
That also gives a lot of indication whether the stream is projectile, not projectile, what is happening, whether the child is crying or not crying, any lump is visible.
Yes, sir.
What Hiren has said is very important. And in fact, in your practice, you will be surprised that very often parents, even from villages, come up with a video showing how the child is passing urine.
Yes, sir.
Yes, sir. Yes.
So in general examination, we have to look for a general condition of the patient. Then in weight, how's it nutrition status of the patient, and then we have to look for whether is a febrile or not. Temperature we have to check. How's the pulse? Whether is it any tachycardia and on there or not. Then the thorough general examination head to toe. Then we have to go for a systemic examination. In that we have to palpate the abdomen. Is there any lump, any fullness? Especially I look for as the patient is presenting with crying while passing urine and increased frequency. I will like to look for any suprapubic fullness, which tell any bladder palpable or is there or not. Then I will proceed further with external genitalia, whether how's the meatus opening, how is it. Then what else is there?
Meatus opening and location. Location is very important.
Okay.
Yeah. Gives a clue about anomalies, no? It starts
Yes.
from there. Yeah.
Yes, it is. Okay.
Bridges?
Yeah, he didn't have
Yeah.
any history of any fever, vomiting, immature urea, no any difficulty in passing stool and walking, no any swelling over the back, no any retention of urine in the past, or no any history of catheterization in the past. So he had a religious circumcision, Antenatal history, there was no any antenatal scan available, and he was immunized till current age, and all the development milestones were normal as per the history given by the parent.
Yeah, go ahead.
General examination, pulse and everything was normal, sir. He was, child was conscious, competent, was able to recognize his mother. On local examination, there was circumcised penis. Meatus was normal. There was no any epispadias or hypospadiasis, or no any hooded prefusal skin, nothing. No abnormality was seen on
When he
examination.
is circumcised, how will there be a hooded prepuce? It won't be there.
Yes, sir.
So just go ahead. When you are presenting a case in an exam, you start speaking unnecessarily things. It invites the examiner's ire and he keeps on asking you more questions.
Yeah.
External for abdominal examination, normal, bladder not palpable, external genitalia normal.
Yes.
Go ahead.
This was the investigation. WBC count was 10,009. Serum create was 0.6. Hemoglobin was 9.2. Sodium and potassium were not.
Okay, let me ask you, if you are given a choice, which is the first investigation you will ask for?
I will order first urine routine, sir.
Right.
Yes.
This is urine routine. What is the definition of pyuria in a child?
More than five WBC per how 5?
Below the age of 2 years, above the age of 2 years, there is some difference. I think below 2 years, it is up to 10 is taken as normal, and above 2 years, it's more than 5, which is taken as abnormal.
Okay, sir.
Just confirm that.
Yes, sir.
Okay, so now urine is normal. What next? And you have seen that the creatinine is normal.
Yes, sir.
Now, if the child had a creatinine of 1.1, would you take it as normal or abnormal?
So it's abnormal, sir.
Abnormal.
1.1 in a 1-year-old child is normal, sir.
Yes.
Yes. So, as the urine routine is normal and the creatinine is normal, slightly count is slightly raised.
Yes.
So, I will like to go with the basic investigation with the ultrasound.
Don't go on the counts, because what happens is
जी sir.
some examiner may suddenly come up, अरे उसको बताओ normal value क्या है, and all labs will show a normal value of 4 to 11,000.
Oh, okay, okay, sir.
Secondly, now in this is not for this particular case, but in your practice, be aware of the fact that there are many labs where the upper limit of what they are able to judge as the lowest value of creatinine is around 0.8 or 0.9. So I don't know the place from where you come and where you will be practicing, but that was my experience when I started my practice. Absolutely, and they would a 6-month-old child with a create of 0.9, and they would say, "Are sir, normal hai." But 0.9 in a 6-month-old child was high.
Yes.
So then when I talked with the pathologist, they said कि हमारी machine में सबसे कम value 0.9 ही आती है.
Okay.
So this can happen because there is a wide variation from lab to lab. That's just for your information, nothing to do with examination.
Okay.
So, okay, urine is normal, create is 0.6. What next?
So I will like to
Ultrasound.
proceed with ultrasound and ultrasound KUB. I would like to see the bladder wall thickness.
No. Anurag.
Okay.
I think Anurag is answering, na?
Swapnil, sir.
Swapnil, yeah, Swapnil. See, when you say ultrasound abdomen, stop at that point.
Okay.
I will like to see this. Nahi. Let the examiner tell you कि ये ultrasound में findings थे.
Okay, sir.
Yes, sir.
ये क्या होता है अल्ट्रासाउंड ऑफ केयूबी रीजन ये जो तरीका है अल्ट्रासाउंड ऑफ ओनली द पेल्विस इज टिपिकल इन द वेस्टर्न regions western world. In India we do an ultrasound of abdomen. Yeah. So can somebody, hmm.
So urinary ultrasonography suggested the bladder was normal, well distended with a regular normal thickness. Prostate was normal in size as per the age.
Hmm.
And left and right kidneys were clinically apparent normal.
So what next?
So Giriraj, what you will do now?
So is the patient as he don't it did not have presented with fevers, and he did not present with previous history also. He just presented with the history of circumcision. We could not able to find any positive in investigation as well in urine routine, which is normal. Ultrasound is normal. Then I would like to see one, as sir told, I like to see any video UFR, as we called in our setup. How the patient is voiding means like so whether maybe because of in this
Okay,
case,
fine.
yes,
Or suppose video is not there, then you can tell na, whenever the
Yes.
patient, how
void,
often he is passing,
Euro-
and you will like to see the stream.
yes sir, and yes sir.
So Giriraj, what you will like to do? Huh? Giriraj, what you will like to do?
Sir, in this case,
Sorry, Swapnil,
yes.
Yes, sir.
what you will like to do?
Uh,
No, see, as he said very rightly, Giriraj just said that only mother is telling that only after circumcision this problem has occurred. Okay,
yes,
number
sir.
one. Number two, all investigations are within normal limit. There is no residual urine. There is no hypertrophy of the bladder. The kidneys are normal. Ureters are normal. Now, what you want to do? Urine is only 1 to 2%. Be bold. Come on, tell us.
Sir, in such patient
The
where
Euroflow,
yes.
can we go for, we can see the flow on
Yeah.
the
Okay. Okay. Fine. So we saw the flow. I asked the mother, we waited for almost 15-20 minutes without pain, and then I saw that the flow was very poor, and like, in between dribbling slowly, and the child was crying. So now this is a situation.
Okay, sir.
So, okay, Girdhar, now what you want to do?
Sir, in if in the flow that urine is very low, then I will like to keep in mind the other possibility which I made during the history. So as I will go for one VCUG for this patient to look how's that bladder outlet, how's it passing, I mean, like posterior urethra, how is it? Then how's the bladder? Is there like is how's the surface, whether is irregular, to look any trabeculation is there or not, to look that.
So you want to do VCUG? Okay.
Yes.
Okay. So, Girdhar? No, sorry, Swapnil, what you want to do?
Sir,
Or, hmm,
since the sonography is normal, we don't know the post-void residue. And we see, sir, next step will be VCUG. We like to look for the bladder outlet obstruction, if any.
so how we want to do? You want to do per urethral, or you want to do suprapubic?
One small suggestion to both Swapnil and Giriraj and all the students. See, what happens is we all then start saying, speaking in terms of say VCUG, MCU, RGU.
Yes, sir.
I personally would suggest you use the full form. Now,
Okay, sir.
why this becomes important is because you are accustomed to lot of short forms.
Yes, sir.
Some of your see VCUG, MCU are standard short forms. I am not denying that.
Yes,
But
sir.
then once this habit comes in, you will automatically start using short forms for a number of things which your examiner may not know.
Yes, sir.
So then it becomes irritating.
Okay, sir.
So बोलो voiding cystourethrogram या micturating cystourethrogram. Fine.
Okay, sir. Will do.
Yes.
चलो तो
Yeah,
MCU
so
film.
okay, but just first tell me how you are going to do it
Sir, in
in
our
1 year
setup,
old child.
in our setup, we used to put a 6 French feeding tube and fill the bladder, and then
Hmm.
we not used to put suprapubic, unless until that feeding tube sometime it's not going. That also, if it is needed, we'll do under sedation only, sir. Will not.
And what about uretherogram, RGU? You are interested in doing RGU?
That sir, in that setup, RGO.
Okay,
Giriraj,
Giriraj.
Yes, sir.
Since this is a
suggestion would be
post-circumcision,
Hmm. Yeah, tell us. Swapnil,
yes,
tell.
yes, sir, there is a possibility of a meatal stenosis being there. So, matlab anterior urethral obstruction or posterior urethra. So, we can do a retrograde urethrophy with VCUG under antibiotic cover with proper consent from the parent.
Sir, but
Swapnil, the moment you say
metal
that,
stenosis will
the
be
phone
more
will not pick up. Yeah, so
metal
Giriraj,
stenosis
you
will be
are,
more picked up in MCU, sir, rather than RGU.
see, you are right, Giriraj.
Yes.
The thing which is most often missed on an ascending urethrogram is a meatal narrowing.
Yes, sir.
So if on examination the meatus looks okay, because if at all there is meatal stenosis following circumcision, that
Yes.
scarring will be very obvious even on clinical examination.
Yes, sir.
So Giriraj, explain in detail how a micturating cystourethrogram is done.
Okay, sir. Sir, as the first before 1 minute, sir. We'll prepare the diluted contrast. Then we put a we'll keep the patient supine as the 1-year-old. He will not allow to put the feeding tube. So we'll used to ask the his mother, whoever relative inside, will put them leg down and hold their leg by assistant, and then we put a jelly and we put a feeding tube and
No, Giriraj, you are missing something.
then
Sir,
then we sir
under
before
antibiotic.
putting this we used to calculate the bladder capacity.
How
That
will you calculate the bladder capacity?
that's sir cough formula, sir.
क्या है?
That's what is it?
Age plus 2 into
Age
30.
plus 2 into 30, sir.
Yeah, this is after the age of
2 years.
2 years. This child is 1 year old.
So age in months into 2.5 plus 38. All.
I think the easier option is weight into 7.
Oh, okay, sir.
Easier option is weight into 7. See, the first thing that how I would, I'm just telling the initial part, and then I would like you to answer the subsequent parts.
Yes, sir.
So after explaining the procedure to the parents
Yes, sir.
and starting him on an antibiotic.
Yes, sir.
See, the biggest problem with all MCU is the subsequent infection and fever that tends to occur. So after start under antibiotic cover, and you should be very well aware of the fact ki which antibiotic you are giving in your institute.
Okay, sir.
ये whenever there is a pediatric case ना ये बहुत सारे queries आते हैं, and hence it is imperative कि right at the beginning during examination the first thing that you should ask is the weight of the child.
Okay, sir.
Because examiner will ask कौन सा antibiotic क्या dose देगा. Right? So under cover of antibiotic, we will first take a plain X-ray KUB. The first film of a micturating cystourethrogram is a KUB.
Yes.
Then you will catheterize the patient you are right. You may use a 5 French or a 6 French infant feeding tube and instill the contrast. Next question will be how much contrast? Second, how much dilution of the contrast? And third, the method of instillation of the contrast. Answer that.
Sir, uh,
Dilution of not more than 1:4, sir.
Preferably, if you want a good thing, make it 1:2 or 1:1.
50% dilution.
अभी problem क्या आता है? Most of the times you are not getting the ionic contrast. These are non-ionic contrast. And somehow I have always felt कि इनका जो density है on an X-ray is not as good as that of urographin or other ionic contrast media.
Yes.
So what I would suggest is you ask if your department is doing it, you are doing it. See, very often, even now, I do the micturating cystourethograms in children personally.
Yes.
But if your department is not going, you ask your radiology department what they are doing. See, what happens in an exam, there would be some departments who would be diluting it 1:1, 1:2, 1:3. If you know what your department is doing or what your radiology department is doing, you can very well defend it by saying कि ये हमारी यहाँ पे की practice है.
Okay, sir.
Okay.
Okay, sir.
Yeah.
Sir,
Only one small suggestion. This is what we do. When we put the catheter, the first thing we do is just to see how much is residual urine and collect that urine, because it is sterile thing for a culture and sensitivity as a reference. This is what we are doing. Okay, go ahead. Swapnil, you are saying something.
Yeah, yes, sir. So after putting the feeding tube and using the attaching the IV line to the feeding tube, we can fill it by the gravity method.
I will give you some suggestions. Swapnil, the weight
Yes,
of
sir.
the child is 5 kg. Tell me how much of diluted contrast you are putting in.
Wait, 35. 60.
Yeah. So your estimated capacity is 35. Ideally,
Yes, sir.
put it bit less than that, say around 30, because you don't want to overfill a bladder.
Yes, sir.
Right. Then
Yeah, just tell us what you will do. Then you'll keep the tube or you'll remove the tube.
Then we'll remove the tube and wait for the baby to void.
once the bladder is filled, you will take a film on full bladder.
Yes, sir.
Why you want to
That's
take a
the second.
film on the full bladder?
To look for passive reflux.
Yeah, okay. Fine. Then next,
Next
see, instead of
we'll
we asking you, you should come out with all the steps.
yes, sir.
So next,
After the full bladder film, sir, we'll remove the feeding tube and wait for the baby to void, sir. One film will be supine, one will be in the lateral, and one will be delayed film, sir.
Post-void film. Now, one of the commonest problems that happens is that because of the pain that happens because of the infant feeding tube that you have introduced, very often the children don't pass urine. And now everybody is on the tenterhooks. The relatives are holding the baby. The radiology technician is waiting with his finger on the chute कि अब लूं या नहीं लूं या नहीं लूं. And the child is crying but not voiding. And as Giriraj had mentioned that very often you keep these babies in supine position, you cannot give them a lateral position. So are there any maneuvers that you can do to help in the child void early?
We can do the creeds, but it is not done.
Reeds is not usually preferred. Anything else?
So usually, like, sometime we used to open the tap, like,
If you have a tap in the radiology suit, that's okay.
yes. Because most of the time, then that kid is so anxious, he will not pass. And
He
sometimes,
doesn't pass.
and sometime even with feeding tube, we start passing while taking the films. That urine is gone. So that
Correct.
also happens, sir. So
So something else. I will tell you the simplest thing that you can do is
yes,
put few drops of urine. Say take 10 cc syringe में 5 cc syringe में take sterile water
yes, sir.
and just put it over the glans or over the bladder, lower abdomen. And
Okay,
very often this helps in the child passing urine.
okay, sir.
Yes, sir.
And above all, the most important thing needed is patience.
Yes, sir.
Because when the child is crying, even those 30 seconds look like 5
Yes,
minutes.
yes,
Okay, so you will take a voiding film and then you will take a post-void film,
yes.
Yes, sir.
right? Anything else, Gaurang sir?
I think that is good enough. Only thing is, my question is that we do only voiding or in such patients, because once I have seen 2-3 times that there may be urethral stenosis, and when we put the catheter, everything is fine and patient flow, everything improves, and they never come back.
Yeah.
So is it advisable to put a little dye in like in RGU and see the urethra, or it is not necessary? In exam, what they are supposed to say?
If you ask me, I would as an examiner won't expect RGO as an answer because possibility of a stricture is very unusual in a child. See, he underwent a circumcision. At the worst that can happen is a meatal stenosis. Nothing ideally should happen to the urethra. So if there is no history of catheterization, then my suspicion is unlikely to be a stricture. Meatal stenosis as such would be diagnosed by my attempt to pass a infant feeding tube, and that should be good enough.
Yes.
Fine, fine. Okay, Bridges, show them the film.
Hmm. Yes, Swapnil.
Yes, sir. This is the pilot film showing irregular bladder wall with wide open bladder neck and dilated posterior urethra with sharp cutoff of sharp funneling of the contrast at the just beyond the prostatic urethra.
Giriraj, you would like to answer something more or add something more to this?
What is this? In that, sir, our one what we are suspecting maybe that is passing well, so that meatal stenosis part is what we rule out, that is gone, sir. So rest of
Other
what
way
we
around,
told.
Giriraj, you read this MCU.
Okay, sir. As then in the shown picture, it's a widening film of widening cystourethrogram. It shows a well distended bladder with irregular surface. Then the bladder neck is opened well. Posterior urethra is dilated, and the and anterior urethra appears to be normal. And there is no reflex on either
Yes.
side, and
Correct. Hmm.
reflex. Yes, sir. And uh, post post-white film is not mentioned, sir.
Yeah. So this is a good enough description.
Yes.
You have covered, you have described the wall, you have described the bladder, you have described the urethra, you have described what the anomaly or abnormality that you have picked up, and very rightly you have mentioned absence of a reflux.
Yes.
Yeah,
So
fine. So now next, what you want to do?
So, sir, as we this is not fine. There we go. So as the patients are initially presented with most probably as a widening complaints associated with increased frequency, and on evaluation, patient blood investigation as well ultrasound was appears to be normal, and we got a positive finding on the VCUG. It's posterior urethra dilated. So I will and as the patient is stable right now, there is a upper tract and creatinine is normal. So and even the electrolyte also normal. So I will plan for a urethroskopy, and I will explain to the his parents that regarding procedures, and if the my as the in the MCU shows that it could be might be the posterior urethral wall, or so it need to be fulguration. So all procedure I like to explain, and I will take a consent for that. I like to sit for the urethroskopy, and followed by bilateral posterior urethral wall fulguration if the
right,
wall is present.
Giriraj, before we go to that,
Yes,
what are the various radiological signs that you would see
yes, sir.
in all radiological evaluation
Yes,
of
sir.
a child with PO walls? First mention ultrasound, then come to VCUG.
So on ultrasound, it's a keyhole sign we see, and ultrasound. First of all, the bladder is grossly thickened, associated with any diverticula we can see, and on ultrasound, so we can see the bilateral upper tract dilated with it could be the grossly gross hydronephrosis, and then as I and on MCU, then posterior urethra, that what you call spinning, no, spinning top.
So see, you're right. One of the most important thing on either ultrasound or an MCU that you are seeing is a dilated posterior urethra, which is the classical that you see in all cases of PO walls.
Yes, sir.
Difficult question that I am asking is, what are the other conditions where you will see a dilated posterior?
Dilated posterior urethra. Sometimes an anterior urethral no posterior urethral dilated. What is that? Okay. Sometimes some urethral stone, it which missed can be presented like posterior urethra dilated, which is stuck at the bulbar urethra. And
Last in the list.
yes, sir.
You
Urethral
also
diverticulum, sir.
less likely. What is Eagle-Barrett syndrome or prune belly syndrome?
Yes,
Yeah,
deficiency of
Giriraj.
anterior abdominal wall with the renal anomaly and pulmonary.
What is the triad of prune belly syndrome? Deficient abdominal wall musculature is right. You get a
Yes,
wrinkled appearance.
yes, sir.
Then you get bilateral hydroureteronephrosis with dilated posterior urethra.
Okay, sir.
And in that situation, it's a functional obstruction. It is not an anatomical obstruction.
Okay, sir.
And the third is undescended testis.
Yes.
If all these three features are not present and any of the two are present, then it is called as an incomplete prune belly syndrome.
Yes.
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 This is one condition where you will get a dilated posterior urethra. Another one, bulbomembranous stricture. Third, have you heard of something called as a Hinman syndrome?
Yes, sir.
Hmm.
What is it?
Sir, it's a severe category of dysfunctional voider, which can be presented with upper tract changes and patient.
Yeah.
Yes,
So what is the other name for the Hinman syndrome?
non-neurogenic bladder, sir.
Right. So what is the basic pathology?
So basic pathology at the that's sphincter incoordination.
Correct.
Detrusor sphincter incoordination.
DSD.
Correct.
This
So
genetic.
that will get a dilated posterior urethra.
Yes, sir.
These are the common causes in a child. When you are talking, especially in an infant, it would be PU walls, it could be a neurogenic bladder, or
Yes.
it could be prune belly syndrome. And towards the end, if the child is, say, about, basically you will diagnose Hinman's more in the adolescent age group or beyond it. So that would come later.
Yes, sir.
Okay. So these are the direct signs that there is a dilated posterior urethra. What are the indirect signs which suggest that there could be a PU wall presentation or PU wall may be present? Or other signs that you will see in a case of PU walls? Irregular bladder, what
Yes.
is described as a sawtooth appearance of the bladder is one.
Yes, sir.
That is trabeculated bladder with some pseudo-diverticuli.
Diabetic.
Another important thing that you should look for is bladder neck hypertrophy, which is seen in this case.
Yes, sir.
If you see where the bladder neck is present in this particular micturating cystourethrogram, you will see that there is a notch which is present.
Yes, sir.
Yeah, that suggests bladder neck hypertrophy. And just to complete the list, another thing which is described is what is described as it is musculus interuretricus hypertrophy. The Mercier's bar, that is the bar which is between the two ureteric orifice, gets hypertrophied. And that people say is appreciated in lateral films. Though very honestly, I have never seen it except in some radiology books or urology articles written on the same. This is what is mentioned as one of the indirect signs which suggests that there is a hypertrophy of the Mercier's bar, which is picked up on a lateral or oblique film. So sometimes what happens is that the child is not able to void adequately and you don't see a very dilated posterior urethra in many micturating cystourethograms. And in those situations, these indirect signs like the presence of trabeculated bladder with pseudodiverticuli, bladder neck hypertrophy is very useful to raise a suspicion that there might be presence of a PU.
Yes.
Right. So what next? Gaurang sir, any other question? Hiren?
No, you are doing very well. They are answering also quite well. The only thing is what I suggest is that Swapnil and Giriraj and all the students, when such a question is asked, start from mild to severe. So you start with the bladder or like posterior whether it is dilated, that is a sign. Then the bladder, trabeculated, saculated, or it is irregular. Then third will be hydroureter, and then so you don't miss anything.
Yes.
Go that way. The same thing in MCU. You will be talking.
Yes, sir.
So you don't miss anything. Don't go haphazardly.
Yes, sir.
Okay?
Yes, sir.
Fine. Yeah. Good. So next what? Now, Giriraj, this is a situation sir has told you all the different radiological appearances, signs, everything is done.
Yes.
So now next what you want to do?
Sir, as I already mentioned that I will like to go for a scopy and to look for any anatomical obstruction. And for that, I will explain to his parents about procedures, and if it is any anatomical obstruction is there, for that I will need to go for a fulguration of if the wall is present, fulguration of the wall. That's it.
So now let us, he is 1 year old. Which
Yes.
scope you will use?
Sir, we used to use 9 French. So for cystoscopy, we use 6x9 cystoscopic sheet, cystoscope to look for is a urethra as well as a bladder, sir. And to look for a posterior urethral wall, where we fill the bladder, and while coming in the posterior urethra, some either assistant to
Giriraj,
put a pressure over the abdomen. Yes, sir.
Giriraj,
Yes, sir.
see, you have a habit of once you start, you go beyond what is asked to you.
Okay, sir.
It's a good thing
Yes,
that
sir.
you are constantly talking,
Yes, sir.
but sometimes this can cause trouble.
Okay, sir.
See, his question was, which scope will you use?
Okay, okay, sir.
To first answer that, what size of scope are you going to use?
6x9 French cystoscope, sir.
9 French will go very often. Say if it's a 6-month-old child, 9 French will go.
No,
6.5 to 7.
6.5 to
See, there are pediatric scopes which are available, and what is available in your department, you can mention it.
yes, sir.
Suppose you are having only a 9 French,
Yes.
and you know that 9 French may not go, then what are you going to do? That is one. And
Yes.
secondly, in the absence of any other armamentarium, is there a way out in which you can overcome this difficulty? This is the next problem.
Yes, sir. So if I don't have the scope which is lesser than 9, and I fairly know that if that scope will not go, I will put a 6 French catheter, and that catheter will keep for 48 hours, and then after 48 hours, I will take for the scope, sir.
Can you use a ureteroscope?
Uretro? Sorry, sir.
URS.
Ureteroscope.
URS 4.5, sir. Mostly
See,
in our
we
setup.
we have been using.
Yes.
Listen, we have been using this
laser.
in the private practice,
Ji, sir.
okay, since long. And I will tell you what we used to do earlier. We used to have Rush ureteric catheter which contains the stylet. And because we didn't have any other instrument, okay, we didn't have any other instrument, so we used to use through ureteroscope, cut both the side and apply cautery wire on outer side and burn the wire. So this is what G.R. Sharma is asking. So one is the ureteroscopy. Difficult because such a small urethra and it slips out and it causes lots of problem. But with a great experience, you learn how to do it. So that is number one he has asked. Second thing he is telling you, suppose you don't have ureteroscope. Something is you have got little larger scope. Now next, what are the other things you can do?
Another way of asking this question would be, what are the different ways in which you can fulgurate a posterior urethral valve?
Earlier there was the image crochet hook which was available.
Is there something called antigrade, retrograde, different ways?
So we can with a suprapubic PCCL, the technique we use in PCCL, we can put in a feeding tube from the penis retrogradely and then fulgurate from above, sir.
Fulguration from above is
See, let's top off perurethral fulguration first. Crochet's hook, Abraham's hook.
Yes, sir.
Gite sir, good evening.
Good evening, sir.
Good evening.
Good evening, sir.
The
Yes, good evening.
antegrade and retrograde already we are discussing. So Bugby is one. Whitaker hook can be used.
Yes.
Initially, we used to call it as a fulguration, but now the terminology has changed and it is called as incision or resection. So better to tell it is like wall resection.
Yes.
If I am not wrong, please correct if I am wrong.
It is incision, sir. Now people use the word
It is
incision.
either incision or resection.
No, I have got to, as you are very right, we have got both bulby fulguration also, and now we have got a resectoscope. I have got a pediatric resectoscope to resect the valve.
Exactly.
It is like a TURP.
Yes.
Exactly, sir.
Even laser can be used, sir.
Yes.
Yes.
In fact, what is used laser? I have stopped using cautery. So electrical, mechanical, electrical, and laser. Mechanical is any hook, Whitaker hooks, Abraham's hook. Electrical is Bugby or a resectoscope, or what Gaurang sir mentioned, the stillet, which is passed through a ureteroscope, or use of a laser. Incision is made at 5 and 7 o'clock position. There are some people who also incise it at 12 o'clock. As Giriraj had mentioned, that the technique is go in, inspect the bladder, fill it up, while coming out, just distal to the veru, stop the inflow, apply minimal suprapubic pressure and see the valve. And then whatever you are using, if you are comfortable using a Bugby, use a Bugby, or use a resectoscope, or you use a laser and you incise. And a very important thing that you need to mention is that we would not do overzealous incision or fulguration of the valve, because you can go in again and do it again after 4 weeks. But if you are very enthusiastic and overzealously you fulgurate that area, then that stricture that happens will haunt you for your entire lifetime. Now, once our discussion is over, at the end, I will show you about 3-minute video showing an antegrade fulguration of the PU valve, and we'll come to that later. Any other question, Gite sir?
एंटीग्रेड का भी सर बता दो, एंटीग्रेड वाल का,
सर
रिट्रोग्रेड
मैं
का
वीडियो दिखा दूंगा बाद में.
चलेगा. अभी वसाकोस्टॉमी का पूछ लिया क्या?
नहीं
Yeah,
सर.
yeah. You can ask.
हाँ,
Ganesh, you can give the
indication
scenario. Yeah.
indication of vasicostomy in a posterior wall, in spite of going for resection.
Now, Swapnil and Giriraj, this is the catch question.
Yes,
His
sir.
last sentence is very important. Despite fulguration of valve, when will you do a cystostomy?
Sir, despite the fulguration, if the upper tract and the creatinine is persistently rising, then it might be because the valve, the bladder is the problem. Then we have to no, sir.
See, I will give you a simple answer.
Yes, sir.
Persistent dilatation, sir.
Yes.
Yeah.
Recurrent UTI and persistent dilatation of upper tracts, recurrent UTI, worsening creatinine.
Yes.
These
See,
can be the.
despite valve, एक simple, I'll make it simplified for you.
Yes.
Despite fulguration, if the clinical parameters don't improve, or there is deterioration of functional parameters and upper tract deterioration continues to occur, then you need a diversion, and in that situation, vasicostomy is preferred.
Yes.
Now, once you answer, and this is my perception, I have never been an examiner. Gite sir can add to it. But if you answer this way, you convey to the examiner that you know what you are answering. Now let him ask you, कि sir क्या देख रहे हो? So sir, at that time, if the nadir creatinine was 1, if the creatinine is increasing, ultrasound is showing increasing hydronephrosis, he is getting repeated episodes of UTI, then I am justified in doing a vasicostomy. Matter
this
and but
this
examiner
this is the answer of म्हणजे excellent student.
Sir, thank you.
Because no, sir, literally it creates question in question and which will guide the exam.
Yeah.
If you answer like that, exam will tell how the functional evaluation will be done. That answer you already know.
Yes.
So that's how you can cover your marks or increase your marks. In spite of telling routine serum creatinine or sonography, ये एक functional बोल दिया मतलब एग्जामिनर को पूछना है कि what functional evaluation you will do.
Yes.
तो ये चीज सीखना है. सर ने जैसा बोला है वैसा एग्जाम में अगर बताया तो तुम्हारा डेफिनेटली बेनिफिट होगा.
To just ask them what is the difference between suprapubic cystostomy and vasicostomy?
So suprapubic cystostomy we used to made on the anterior wall of the bladder, but in the vesicostomy we have to made and in the in at the level of what you call
In the dome.
at the dome,
Yeah.
because if we made at the anterior wall, the
देखो,
posterior wall will prolapse.
नो ये SPC रहो या कुछ भी रहो एंट्री वाल कुछ होने वाली है.
Yes, sir.
वो तो कोई पोस्ट वाल को नहीं होता है.
Yes, sir.
तुम
Yes.
ट्रॉकर SPC करो या वसाकोस्टॉमी करो या ओपन SPC करो, इट इज ऑन द एंट्री वाल ओनली. सर का क्वेश्चन ये है कि SPC एंड वसाकोस्टॉमी में डिफरेंस क्या है, ये पूछ रहे. क्वेश्चन पहले अच्छा सुनो और उसके बाद में फिर आंसर करो. The first question is, what is difference between SPC, suprapubic catheterization, and vasicostomy?
See, you are saying that you want to do vasicostomy, na?
Yes.
That means it is definitely not suprapubic, or it has got some advantage over because suprapubic is such a simple thing.
Yes.
If both are giving you the same result, why you want to do vasicostomy?
What is the purpose of vasicostomy?
Have you ever seen, Swapnil Giriraj, have you ever seen a suprapubic cystostomy where a tube is not put?
Yes, a tube will.
Yes.
So where you put a tube is a suprapubic cystostomy, and when you connect the bladder to the skin
Yes.
is a vasicostomy.
Yes.
That's the first thing.
Yes.
So another question, by doing a suprapubic cystostomy, is there any change in posterior wall of bladder?
Pardon, sir?
Is there any change in the posterior wall of the bladder? If you place the suprapubic cystostomy, the purpose, very much purpose here of doing a vasicostomy is to make
Bring
the posterior wall of the bladder
wall.
taut
Yes.
Okay.
by bringing dome to the skin.
Yes.
Okay.
In SPC, we just make the hole and place the catheter.
Yes, sir.
So that it will, if you remove it, it will start passing urine from below, it will heal.
Yes, sir.
It will close within no time. Understood. But when you are bringing the posterior wall in front, the bladder, as sir said very rightly, you are making it taut, and posterior wall is coming, so the anterior wall is not fusing, and it will not close unless and until you make an attempt to close it.
Yes, sir.
Okay, so that is one thing. Sir, you wanted to ask about upper tract, how to tackle the upper tract, Sharma?
So what we will stick to this particular case.
Yeah.
सर अगर वीडियो है ऑपरेटिव का तो वो दिखाते हैं, नहीं तो we will say कि अभी फल्गुरेट कर दिया, what next?
Yeah. We don't have video. You can just ask them.
So fulguration is done 5-7 o'clock position. Now there are some people who believe that if there is a bladder neck hypertrophy, you take an incision of the bladder neck also. I am not a proponent of the same. I would say कि you don't do it at the first instance, because once you relieve the obstruction, it's very much possible that the baby may pass urine much comfortably and you don't need to do anything else. Now, you have put in, you have fulgurated, would you keep a periurethral catheter or not?
In our
Yes,
institute,
sir.
we used to put catheter for 48 hours, and after 48 hours, we remove
What
the
catheter?
normal PVC. Instrument.
Which catheter? You will put a
Foley.
Foley, you will put an infant feeding tube.
Sir, we'll put a infant feeding tube. The Foley's catheter will inflate. Already the bladder capacity is low, and
In this case, the bladder capacity is so high.
100.
We are talking about this case. In this case, what would you put? Infant feeding tube or a Foley? Whatever is your choice, tell me the number. And how will you fix it? If an infant feeding tube, how will you fix it for 48 hours? If it's a Foley, how will you? Then I will ask you questions on Foley. Yes, Swapnil.
Swapnil, what you will put? Chalo, come on.
Sir, I'll go
Quick.
for infant feeding tube, sir, because Foley's will have to inflate it, and already it is a thickened bladder also. It might cause increased sensitivity, may also obstruct the urethral orifice. Maybe.
Swapnil, all said and done, it's more of a theoretical answer. You can put an infant feeding tube or you can put a Foley also here. Both are equally good. If you have put a pediatric Foley, you inflate the balloon by how much ml?
2 to 3
3
cc.
to 5 cc.
3 ml, 4 ml, 5 ml. The maximum capacity is 5 ml.
Yes.
Okay, let me ask you one question. Have you, there are first question. What is the smallest size of Foley which is available?
6 French.
Right, it is 6 French. Now, if you see the pediatric Foley 6, 8, 10 French,
Yes.
they have got a stillet.
Yes, sir.
Yes, sir.
But you don't have any Foley above 10, that is 12 French onwards, which has a stillet.
Yes, sir.
ऐसा क्यों है?
To negotiate in the pediatric urethra, I think that would be the.
Yeah, you are right. You are very close to it.
Because the kids while passing, like in OT is okay, is different. Like in normally, when we put a catheterize the kids, they will contract the external sphincter very tightly. So that time, if the slit is not there, it will not go. But in a sedated patient, this theory not. I'm not sure. Sir.
You are right in your answer.
Yes, sir.
It is very difficult to introduce a Foley of 6, 8 or 10 French without a stillet.
Yes.
If you have put a catheter in a child, you will realize it.
Yes.
कभी-कभी कुछ sisters बहुत intelligent रहते हैं. When they give it, they remove the stillet and give it to you, and they throw it away by the time they give it in your hand.
Yes.
And you try passing it, it is very difficult.
Yes.
You all just take 2 Foley catheter tomorrow. One is 12 French and one is 6 or 8 French. And just see the stiffness and flexibility.
Yes.
So if you placing the 12 French, is it necessary to make it straight? No. By putting the stillet 12 French, 14 French, 16 French, 18 French? Because the stiffness is more. Here, the catheter is very small, and if you remove that stillet, it will bend like this. It not able to negotiate the curves of the urethra.
Yes.
That's why it is necessary to make it slightly stiffer by placing the stillet.
Yes.
Okay. So you have placed an infant feeding tube, Swapnil. When will you remove it? And your subsequent post-op protocol.
So at least for in our institute, we keep at least for 24 to 48 hours.
Yeah, again, my suggestion would be, Swapnil, when you answer, at least, तो अब ज्यादा कितना रखोगे? कभी कभी क्या है, एग्जामिनर का मूड अच्छा नहीं रहा तो फिर वो ऐसे वर्ड्स को पकड़ के वो लोग खींचते रहते हैं.
Yes, sir.
Be very specific. See, what the examiner wants to know is your thought process, whether you have seen such cases, and if such a case is given in your hand, will the child be safe in your hands? This is what they are just interested in. This is my perception in whatever few exams that I have given. So you say, in your institute, it's a practice to keep it for 48 hours. Sir, I will keep it for 48 hours. And after 48 hours, I will remove the catheter. And you want to be more specific. We will keep the child under antibiotic cover, monitor him for his vital parameters. And after 48 hours, if he is afebrile, comfortable, then I would remove the periurethral catheter and then see the way the child is voiding.
Yes, sir.
See,
After
if you
this,
say
there
1 or
will
2
be more
hours,
questions pertaining to this.
so if you say 24 to 48 hours, he will ask you when you will remove after 24 hours and in which cases you will keep it for 48 hours. So
Yes.
whatever Dr. G.R. Sharma is saying, answer that way.
Yes, sir. Yes, sir.
Yeah. Okay.
So,
Now second thing,
in-
once you have removed the catheter, what you will do?
after removing the catheter, we'll observe the baby for passing urine, look for the flow, improvement of flow, whether he's crying and wincing like before he was when he was passing urine. Then follow up after, we'll continue with antibiotics for 5 to 7 days, and then follow up after 1 month with repeat USG to look for changes in the up in this section. So we'll
Yes.
Yeah, Giriraj, you want to add something?
Yes, sir. In after 48 hours, we remove the catheter and then we'll like to make a video. We ask the patient to make a video. So we'll see the video, whether is there any difference, whether he's passing with the same crying or he's passing comfortably. If he's passing comfortably as the patient, on discharge, we just used to give some painkiller SOS. We not advise antibiotic as the patient there is no reflex and there is no infected urine. So we used to ask the patient to review after 2 weeks in OPD, and then again we'll see how is the flow, and then every in this patient as the upper tract is normal, creatinine is normal in this case, then every 3 months we used to follow up with ultrasound, urine routine, and creatinine for particular to this case.
Very good way of answering. But another thing that you can add is
Yes.
the basic reason why this child presented was with increased frequency.
Yes, sir.
So if you again mention this in your viva, yes, we would look how good he is symptomatically.
Yes, sir.
So that would see, आपको एग्जामिनर को बताना है कि हाउ वेल यू हैव अंडरस्टूड द केस और मैं क्या ध्यान रख रहा हूँ, बाकी कुछ नहीं.
जी सर.
बाकी तो यार हम भी अभी तक सीख ही रहे हैं, एंड वी आर स्टिल लर्निंग एंड यू पीपल आर आल्सो लर्निंग.
Yes, sir.
So just convey this. So you have answered everything well. Importantly, you have also highlighted this fact कि very often, especially in children who have got upper tract dilatation, and in these children आपने कुछ instrumentation किया, catheterization किया, तब तक infection नहीं था, बाद में infection होना शुरू हो जाता है.
Yes, sir.
This is something also which you need to remember, and you have mentioned that, so that's very nice on your part. Yes, you will look for infection. Yes, you mentioned every 3 monthly, but you have not mentioned a functional evaluation. So that is one aspect which you should always mention, that you will do a functional evaluation by doing a DMSA scan.
Yes, sir.
That should complete the things.
Yes.
Okay, when will you do the check cystoscopy?
Sir, we in our institute at the patient if is passing normal urine and the if till the patient is not able to void UFR, we'll used to see the video UFR. If video UFR is good, urine routine is good. There is no pus cells or there is no albumin, and if there is no raised creatinine or there is no upper tract, we usually will not do check scopy in this case unless until patient upper tract deteriorate to see whether any residual walls or any hypertrophic bladder neck. For sure, otherwise we won't do sir in our institutes.
In this patient, okay, everything was
Giriraj,
normal.
again, one thing,
Yes, sir.
don't use abbreviation UFR.
Okay, sir. Okay, sir. Sorry, sir.
Yeah.
You mention
So
visual Euroflow, how
Yes.
his stream is.
Ji, sir. Ji, sir.
Question asked was when you will do a cystoscopy, and your answer is not related to that.
Ji, sir.
Your answer is when you will not do cystoscopy. ऐसा आंसर दिया था. उन्होंने पूछा था कब करेंगे, आपने बता दिया कब क्यों नहीं करेंगे. उनको एक्सपेक्टेशन ये था कि अपना रूटीन आप जो भी बताया है उसमें कोई तो समझो क्लिनिकल डिटोरेशन मींस वाइडिंग सिम्टम्स का रीअपियरेंस हो गया.
जी सर.
पोस्ट वाइड रेसिड्यू बढ़ गया.
जी सर.
रेनल पैरामीटर्स डिरेंज हो गए. हाइड्रोनेफ्रोसिस बढ़ गया प्रॉक्सिमल.
जी सर.
तो मैं सिस्टोस्कोपी कर सकता हूँ या फिर रेडियोलॉजिकल पहले VCUG इन्वेजिव की नॉन इन्वेजिव.
जी सर.
तो ये डिस्कशन उनके तरफ से आना चाहिए. जितना पूछा क्या पूछा था कि सिस्टोस्कोपी कब करेंगे.
सॉरी सर.
So the first thing you should say that a cystoscopy, when you will do, when the patient's stream is, parents are examining and telling you his stream has not much improved.
Okay, sir.
Child is so clinical,
Okay,
and then all this functional.
Okay.
Okay?
Yes, sir.
Fine. But suppose everything is fine, still you will like to do cystoscopy?
No, sir.
So then how will you confirm? There is something called as a subjective and objective. So subjective is what the parents are telling you that
Yes,
no, now he's not crying and the stream is better.
Sir, objective evidence with the visual UFR and along with PVR we can check, sir. So if it is okay, then so
Okay.
yes.
So
That you
yeah.
are telling that what you are doing at your institute, because see, this particular follow-up protocol varies from person to person, institute to institute.
Yes, sir.
So if this is what is followed at your institute and you are sticking to it, that's a very good thing.
Yes.
Somebody asked you ki, suppose you do an MCO
Yes.
after 2 months, and how will you know that pre-fulguration and post-fulguration MCO there is an improvement? Because if you have seen MCOs done after fulguration also, you will find that there is some dilatation of the posterior urethra which is present and persists for a very long time. It doesn't disappear very quickly.
Yes.
So a small homework to all the residents: find out what is meant by a posterior urethra anterior urethra ratio. So there are some institutes which do routinely an MCO after 6 to 8 weeks, and they compare it with the pre-op MCO. And this is one way of objectively evaluating, because you don't need to subject the child to anesthesia of a cystoscope.
Yes.
Yeah. Okay.
Yeah. And always don't forget to mention a functional evaluation of a DMSA scan.
Okay, sir.
here, can
Yeah.
you just ask them about when to do ureterostomy or nephrostomy?
Sir, I personally feel I will tell you, pediatric surgeons are very fond of doing ureterostomies. And I have rarely come across urologists who primarily will do a ureterostomy. So when I was a student, and at that time, 6th edition of Campbell was in picture. In the last 6 months, the 7th edition had come. That time, the standard answer used to be कि the creatinine remaining more than 1.7, marked upper tract dilatation, and presence of bilateral hydroureteronephrosis, and no reduction in the creatinine despite putting in a catheter are indications for diversion. Now, if bilateral reflux is present, they would advise a vesicostomy. If it is no reflux is present, then they would suggest a ureterostomy. But that was an old concept. At present, if you ask me, vesicostomy is preferred, whether it is unilateral or bilateral reflux. The only indication would be markedly tortuous ureters, where despite doing a vesicostomy, where you classically call it as a Bloxholm's vesicostomy, where you reach up to the urachus and that dome is opened and anastomosed to the skin. Despite that, you know that this dilated, markedly tortuous ureter is not going to drain properly. In that situation, you may do a loop ureterostomy. But these indications in the present era where good antibiotics are present are far and few. And I have come across n number of cases of PU walls, but in my 25 years of practice, I have never done a ureterostomy. Vesicostomy, yes. Sometimes the child has been so sick that on couple of occasions I have done a vesicostomy under local anesthesia. But I have never had the occasion to do a ureterostomy. And nephrostomy, the older textbooks mention creating a pylostomy, high loop ureterostomy, low loop ureterostomy, and ureterostomy. But I think these discussions are nowadays far and few, because see what happens is very often these children are picked up prenatally and immediate postnatal before further deterioration occurs. You don't get child coming. See, this child coming at 1 year is going to have a very good prognosis because he was not very symptomatic. The creatinine is good. But otherwise, you don't come across these type of cases nowadays. These cases are picked up prenatally and you are able to intervene very early in the postnatal period. Gite sir, anything else you would like to?
Yeah, one of my radiologists showed me antenatal by posterior valve fulguration, transuterine vesicle. Yeah, endoscopically.
I'm totally agreeing with Gyanendra Sharma sir, because I have also never seen any urologist who has done ureterostomy, pylostomy. These are theoretical. Everything is theoretical. So initially people may be doing. Now, majority times vesicostomy will definitely suffice, except one indication what sir has already told, because if there are gross dilatation and secondary obstruction in the ureter, then that ureter may not drain in the if you have done a vesicostomy. In such situation, you have to go for proximal diversion. Otherwise, there is no any indication for going for proximal diversion.
Another thing that is often asked in exam is that there is persistent dilatation. So what are the causes of persistent dilatation? First and foremost, mention poor bladder compliance. Second is diuresis, which is occurring. Third, I would say persistence of reflux, bad bladder, marked diuresis, which persists. And the fourth thing is obstruction at the uretrovesical junction, which is the least likely. Then incidence is less than 5%.
Agreed.
And for all the residents, remember, all these kids with PU walls, especially which are diagnosed in the neonatal period or perinatal period, their kidneys are never good. And they always have poor concentrating ability. So what you need to remember is कि even if the child is having loose motions, इनका output कम नहीं होता है. And suddenly you will find कि नहीं, there were loose motions in the morning, but the sister says that the output was good, and by evening you will find that the child is in a very bad shape. So don't rely on output to assess the hydration status in these children. Practical thing to remember, I don't think this will be asked in exam, but my intention is you should be good urologist. Exam to pass हो ही जाते हैं. That's the easiest part of the entire career.
Such a wise statement you have made.
And that is true, sir, because if you don't know the exact, I personally take urology like physics. हाँ, क्योंकि अगर वो तुमको प्रॉपर फंडे क्लियर नहीं हो गए हैं तो तुम कौन सी भी एग्जाम पास हो गए तो उसको कोई मतलब नहीं.
Yeah. True. Fine. So, anything GR
आप
Sharma sir?
एंटीनेटल मैनेजमेंट का भी बता रहे थे, तो एंटीनेटल मैनेजमेंट में एंटीनेटल वॉल का भी ये है, ट्रीटमेंट का भी जिक्र है बहुत जगह पे, या फिर vasocoamniotic stenting to stents to maintain the pulmonary function, that is another antenatal management. उसके ऊपर बेसिकली थ्योरेटिकल क्वेश्चन आता है बहुत बार. लॉन्ग क्वेश्चन भी आया है बहुत बार और शॉर्ट नोट भी आई है. तो व्हाट इज द एंटीनेटल मैनेजमेंट ऑफ पोस्टीरियर वॉल, तो ये जस्ट थियरी के लिए इम्पोर्टेंट है, प्रैक्टिकली बहुत बार वहां तक जाता नहीं है बाबा. तो
चार्ट है कि ये पैरामीटर्स है यूरिन में, तो वो सोडियम इतना है, ये इतना है, तो इट इज यूजफुल, ये है तो वो उतना यूजफुल नहीं है. सो आई थिंक गो थ्रू कैम्बेल एंड गेट इट.
गुड एंड बैड प्रोग्नोस्टिक फैक्टर में वो सब चीजें आती है. उसका दूसरा इम्पोर्टेंट ये है कि दिस इज द ओनली डिसीज आई फील इन यूरोलॉजी व्हिच इन्वॉल्व्स ऑल सिस्टम ऑफ द बॉडी.
Yes.
Yes, sir.
And in this disease you have to follow lifelong. Such patients need follow up lifelong. उसको तुम ऐसा खत्म हो गया इसके बाद में लगेगा नहीं, ऐसा बोल ही नहीं सकते. कुछ ना कुछ तो फिर आ ही जाता है. तो lifelong risk है.
We haven't touched wall bladder syndrome so far.
Exactly.
Maybe some other class we will take in about wall bladder syndrome.
Wall bladder syndrome, settle wall, delayed presentation, majority things are there. We will probably need one more class.
Fine. So,
Sir, if you permit, मैं 3 मिनट के 2 वीडियो दिखाऊं.
Yeah, please. Yeah, sure.
आपने बोला था तो सर, can I share my screen?
Yes, sir.
Yeah, please. Brijesh. Yeah.
Sir, are you able to see the screen?
Yes, sir. Yes, sir.
Yeah, we are able to see. Yes.
The question is when to do it and why to do it. And I'm talking about, and this is my presentation, I think in one of the national conferences. And when Gaurang sir said ki if you have anything, you present it, and luckily I have this on my laptop, so I'm just sharing it. The question is ki we often in exam and when we are talking, we talk about fulguration per urethral. But when we talk about antegrade fulguration, the question is when to do it and why to do it. See, you are able to do it only and only if you have a vasicostomy, or the second situation is where perurethral is not possible. Then the first description about antegrade fulguration, I think, was way back in 1976 in Journal of Urology, where forget the name of the person who described it, where he made a, like as you do in PCCL, you make a puncture, put an amplas sheath and small ampulla sheath, and through that you pass a short ureteroscope and fulgurate it. But whenever I have done it in cases where most of the times a vasicostomy has been done either by me or somebody else. On 2 occasions, the child was so sick that a urologist did an SPC, and a suprapubic cystostomy, and they put a 10 French or a 12 French Foley catheter. In 4 to 5 days, the child stabilized from infection and other things, and from that track, we could very easily fulgurate the valve. Why to do it? Like somebody may ask, if there is a vasicostomy, why not to do it periurethral? The reason is, very honestly speaking, you are able to visualize and appreciate the valve far better antegrade manner than in a retrograde manner. And you will see it now. Now, this is a video where I am using a 10 French pediatric resectoscope. And through the resectoscope, what you are seeing now is the bladder neck. I have entered through the vasicostomy, and now I have gone in the posterior urethra. And now you see that the path is closed. You are seeing the veru, but you are not seeing anything beyond it. You have done a antegrade cystoscopy, you are very often able to see a passage. So what I do is I pass an infant feeding tube. And now if you see, I move my cursor, and this is the valve that you are able to appreciate. I hope the residents are able to appreciate the valve here. This is the valve. So now this infant feeding tube is brought in the bladder, and I go again with the resectoscope. You are able to see the valve very clearly. And then using a resectoscope, now this video is from 2006. It's not a new video. I have a couple of videos with laser, but they are not included here. So this is a resectoscope hook. I use an infant feeding tube because it does not disseminate the current. And I will use a very small coagulating current. With my cautery, the setting is at 30 watt. You get these bubbles and you have incised or fulgurated, whatever you call it, the valve at 2 places. When I do it antegrade, I do it at 3 and 9 o'clock. And then rotate it. The valve on this side is also fulgurated. So even if the hook touches the infant feeding tube, it being inert will not transmit the current, and the urethra is spared. And you are able to see that the valve has been cut. I take back the infant feeding tube, and then with the flow of water or saline, I know that the opening, now you are able to see the opening over there, which means that the valve is not obstructing. Otherwise, with an antegrade flow of the saline, you will not see the opening at all. And then I again pass an infant feeding tube periurethral, bring it out through the vasicostomy, and just tie it, one end from the urethra, one end from the vasicostomy, and tie it over the abdomen, keep it for 48 hours and remove it. Interestingly, few of my patients have had a closure of vasicostomy, but in majority, after about 4 to 6 weeks, I go in again, do an antegrade cystoscopy, see if the valve is present, and if there are no residual valves, I just close the vasicostomy. Now, this has been my experience that if somebody sends you a case with a vasicostomy where the valve has been fulgurated and he wants to know whether a residual valve is present or not, the best way is to look at in an antegrade manner rather than doing a retrograde cystoscopy. Because if you do a retrograde cystoscopy, invariably you will feel, अरे यार ये छोटा सा valve है क्या, एक मैं छोटा और cut ले लूं क्या, and this more often than not will cause damage to the urethra. So my experience is that if you have a vasicostomy, nothing better than fulgurating the valve in an antegrade manner. You are able to really appreciate it very well. And subsequently also, an antegrade visualization gives you a far better idea about the presence or absence of valve. And then you can close the vasicostomy safely. Gite sir, your experience?
I
Sir,
think
I have,
anti-grade.
I have not till date. I have not fulgurated or incised the wall antegradally. Whatever I have experiences with retrograde only.
Yes, I think most of us has run only for urethra only. So because ER has done many pediatric cases, probably he has seen all these things.
Sir, I get a lot of
But-
pediatric surgeons
but
have done.
But I agree, when you want to avoid the urethra, or when it is necessity to avoid the urethra, it is always better to avoid the urethra. 3 sentences. Antegrade is better.
And sir,
Yeah.
if you are using laser, nothing like it. You are able to really precisely cut it.
And that person who has done the antegrade is, that is, if I am not wrong, it is Perlet, the name of the person.
There is only one article in Journal of Urology which mentions.
Jaunitz and Perlet.
Okay. Fine.
Any
Anything?
questions from any of the question from Harsh Mehta? This is for antegrade fulguration of the walls. You have a vesicostomy, you go antegrade and you fulgurate it.
Yeah.
Yeah, one more question from Harsh is that the value of sodium chloride. See, if you look at the chart which is given in Campbell, it says good prognostic factors and poor prognostic factors. And when you know from the biochemical parameters कि यार इसका कुछ होने वाला नहीं है, you may do anything, but things are not going to improve. There is no point in subjecting the fetus and the mother to a procedure which is having a lot of its associated risks. So in that scenario, you avoid doing it. The fate is sealed. But where you think that the prognosis is good, then you make all out attempts to salvage whatever you can. So that is why these biochemical parameters are important.
I think everything is covered.
Yeah.
And as you
See,
said very
continence in
rightly,
these patients asked by Harsh, I think we will have to take a separate class for the same and talk about wall bladder, because incontinence on account of a bad PU wall fulguration or incision is not very common, to be honest. Those people who do it, most of the times you may end up having a stricture, but incontinence due to damage to the sphincter is less likely.
yeah.
That would be a part of a wall bladder syndrome, which in itself will require a separate class. I don't think we can cover it in a few minutes.
No, we will cover it with a neurogenic bladder then.
Yeah.
We will take it separate. Okay.
Sure.
Okay. Chal.
Good night.
Thank you. Thank you very much.
Good night, sir.
Good night to
Good class.
everybody. Yeah.
Good night, sir.
Good night,
Good
sir.
Good night, sir. Good night.